Hi, my name is Nirav Seth. I practice cardiovascular medicine at Holyoke Medical Center, and today we're going to talk about congestive heart failure. This being a heart month, just a matter of disclosure. This is for general public information and shouldn't be taken as medical advice. And I would refer you back to your doctor if you have any heart failure related medical condition. So the first slide will start with definition of heart failure. Congestive heart failure is a medical condition which is a complex clinical syndrome where the heart is not doing what it's supposed to do and is not able to meet the needs of the body and the tissue. When we talk about congestive heart failure and when you will see your doctors, you will basically be described and fall into two main subtypes. You will hear about systolic congestive heart failure or heart failure with reduced ejection fraction. And the second type is diastolic heart failure or heart failure with preserved ejection fraction. The difference between the two is based on the pump function of the heart, and a cutoff of less than 40% defines you to have systolic congestive heart failure, and ejection fraction above 50% puts you in a category of heart failure with preserved ejection fraction. These are main two subtypes defined by American College of Cardiology and American Heart Association guidelines. But I also like to put into two other categories, three other categories. Patients having congestive heart failure due to valvular heart disease. Sometimes they are linked into the former two categories. Also, congestive heart failure related to pericardial disease. Pericardium is a sac that covers the heart, and sometimes constriction to the pericardium can cause congestive heart failure syndrome. And then there is predominantly right-sided heart failure where it doesn't involve the main pumping chamber of your heart, which is the left ventricle or the left side of your heart, but predominantly involves the right ventricle and the right atrium and the valves on that side. And that's a complex syndrome by itself. We won't go into details of that today. So this slide is telling us about classification of heart failure. This is a WHO classification of heart failure based on stage of heart failure as well as the patient symptoms and with the heart condition. So basically, you divide them into four stages. Stage A is when patients typically have no symptoms but have risk factors to develop heart disease. This could include hypertension. This could include metabolic syndrome. We'll go into details in the next slide. Stage B is when you have some kind of structural heart disease but have not yet developed heart failure syndrome or heart failure symptoms. This includes patients having reduced heart pump function called as cardiomyopathy, or if they have significant thickening of the muscle of the heart or a valve disease, but they yet don't have symptoms, and they usually have no restriction to their functional status, and they're considered class 1. The next is stage C, which is where you have evident heart failure. Either you have been admitted to the hospital with heart failure or you have a diagnosis of heart failure. You now divide these patients into four classes. Class 1 is patients who have no functional limitations. They can do pretty much whatever they want to do. Class 2 is they're getting symptoms with their daily physical activity or exertion. And class 3 is they're getting symptoms with minimal exertion or minimal day-to-day activity. And class 4 is when they develop symptoms at rest. So the difference why we divide them into these classes is that as we progress in classes from class 1 to class 4, it impacts short-term and long-term prognosis, and that's important to classify patients according to the class. And sometimes the treatments are based on what class patients belong to, and you would not treat patients who are in class 1 with the same therapies as patients are in class 4, for example. And then the last is stage D, where patients basically have advanced heart failure and they are either dependent on infusions or are very markedly limited and basically need advanced therapeutic care in terms of device therapies or other interventions. So why is heart failure important? Heart failure is one of the heart conditions that is actually increasing incidence and prevalence, and that is due to a lot of different factors. One is that we have an aging population. We are very good at treating other heart conditions, and patients living longer and ended up getting eventually congestive heart failure. The incidence at age 65 to 69 is 2%. And when patients reach above 85, the risk goes up fourfolds, and almost 8% of patients develop heart failure. So it's a very common condition as you age. Your lifetime risk of getting heart failure is about 20% about the age of 40 years. Once you have a diagnosis of heart failure, it is a pretty morbid and mortal disease. About a 50% survival rate in 5 years, matching some of the cancer survival rates. And this is underestimated in patients with heart failure. But there are treatments. You can change this. And depending on which stage of heart failure you are, the prognosis can be quite different. So if we identify heart disease early and treat them early, we can obviously change the prognostic curve of the patient. There are about 1 million hospitalizations in the United States. And once you're admitted to the hospital, there is almost a 25% readmission rate. So there's a lot of morbidity associated with heart failure. And it's a very expensive disease. The United States spends about $30 billion taking care of patients with heart failure. So it's a very important disease. We need to do everything possible to identify patients early and treat them aggressively so that we can improve their quality of life. So as we had mentioned earlier, there are certain risk factors that make you more prone to get congestive heart failure. And this puts you in the stage A of congestive heart failure by WHO classification. The commonest risk factor is hypertension. So it behooves us that once we have a diagnosis of hypertension, we want to take care of that very aggressively so that we don't end up developing heart disease that leads on to develop congestive heart failure. Diabetes is another risk factor that is very common, and patients with diabetes end up having various different heart problems that can go on to develop congestive heart failure. Metabolic syndrome is a syndrome associated with obesity, which is by itself a risk factor for congestive heart failure, but it is basically a syndrome where you have lipid abnormalities and you have insulin resistance, kind of a precursor for diabetes, with abdominal obesity that leads to heart failure. Atherosclerotic heart disease, which is basically means coronary artery disease. So if you had a prior heart attack or you have stents, you are again a risk factor for developing heart failure eventually. And often under-recognized atrial fibrillation, which is coming more and more to the forefront. It's a common arrhythmia again, where you get more incidence of atrial fibrillation as you age, and then you also have with atrial fibrillation development of heart failure after a few years. So they can be a coexistent condition, or there could be atrial fibrillation leading to heart failure. So what are some of the symptoms that can be associated or make you think about heart failure? There are basically two main categories of symptoms. One is exercise intolerance, where you're not able to do what you were able to do a few months ago. You're getting more shortness of breath or you're getting fatigue. Those can be symptoms of heart failure. Obviously, a lot of other systems, when are involved, can cause those symptoms, but you always have to think, if you have risk factors and you develop these symptoms, that am I having any problems with the heart? And you can then approach your doctors and get further workup. Congestion is the second symptom, basically any form of swelling in your legs or abdominal distension or getting shortness of breath at rest or sudden weight gain, which is unexplained, is something that you can get with congestive heart failure. And that's why one of the description is congestive heart failure, where part of the syndrome is related to congestion. So what are some of the tests that your doctors might suggest when you are suspected or are considering having congestive heart failure? Always starts with a good history, and the history involves all symptom onset, how long have you had symptoms, but also includes symptoms related to your past medical history, your family history, your social history, which is all part and parcel when you evaluate a patient with congestive heart failure. A good history is very, very important, followed by a good physical examination to see what kind of heart failure at what stage patient is, to help guide treatment. Obviously, after that, blood work. Very commonly, we do common blood work, and then go on to EKG, where we can diagnose if patient has had any problems, any arrhythmias. Go on to, very importantly, cardiac biomarkers. This has a lot of focus when you're not sure if patient is having congestive heart failure. We often use a blood test called as BNP or pro-BNP, and you may come across that. Your physician describes the test to you. Also, troponins, if you're suspected to have coronary artery disease or acute myocardial infarction, can be drawn in patients, when we are suspecting congestive heart failure. Going on to imaging tests, chest X-ray is a baseline test that can tell us if the lungs and heart size and if there's fluid in your lungs. You go on to echocardiogram, which is basically an ultrasound of the heart, very, very commonly done test. It's actually cornerstone of diagnostic testing for heart failure, where we can get a lot of information. We can get how well the heart is pumping, and we can go to get patients to be defined into either heart failure with reduced ejection fraction or heart failure with preserved ejection fraction, as we had mentioned before, based on the findings on the echocardiogram. And we can get a lot of information regarding their valves. We can get a lot of information regarding the covering of their heart, pressure buildup in the heart. So echocardiogram is really a cornerstone testing. Stress testing can be ordered by a physician if they are suspecting that you have atherosclerotic disease, where you want to know if they have underlying blockages in the heart arteries that will impact their treatment. Sometimes when echocardiogram is not enough, or we are suspecting some very advanced cardiac disease, we can suggest cardiac MRI to further delineate as to what kind of problems patients might be having. Patient can then go on to have cardiac catheterization, which is an invasive test, which involves measurements of pressure inside your heart and also looking at the coronary arteries and measuring pressures across the valve, which can help with therapy in a patient. And then you can also have endomyocardial biopsy when you not sure as to what kind of infiltrative disease the patient has, or if patient has any kind of inflammatory disease, which can guide therapy as well. So when I see a patient with heart failure, right the first time, we set together treatment goals, and my goals are very basic. When I start talking to patients about heart failure, we are talking about obviously improving symptoms and improving functionality. That's the primary goal, to improve quality of life. Very often, heart failure can be progressive disease, can be very difficult to treat, and patients are very symptom limited. And one of the goals is to just get patient back to their usual functional status, what they enjoy doing. Second goal, when we go on, we talk about reducing hospitalizations. As I mentioned earlier, heart failure is one of the leading causes of hospitalizations in the country, and there's a very, very high readmission rate. So we want to kind of focus on reducing that and providing patients tools to see how we can manage to reduce hospitalization. And when we achieve these two goals, in the process, we are aiming at prolonging life. So adding quantity to the quantity is the next goal. And there are various therapeutic options that help us with that, with prolonging life. And when patients are in very advanced stages of heart failure, we discuss about advanced care planning and their goals and what to expect out of treatment. So there is a lot of goal decisions around that. Is obviously a team effort between patients, their providers, their family members, and sometimes we involve visiting nurses and other case managers to kind of help patients. So it's a multi-team disciplinary approach that we pursue with the treatment goal setting. Going to general treatment, there's a lot that patients can do to help themselves and help their condition. This is very, very important. Often gets sidelined when we start talking about therapeutic approaches, but very important part of treatment is education of the patients and the family as to what's going on, what is the diagnosis, what are the treatment options, and what is the prognosis, and what can patients do to help themselves to prevent hospitalizations and improve their symptoms and quality of life. Very important dietary restriction is a restriction of sodium intake. Sodium is a common element in lots of foods. So part of the education process involves identifying foods that have high sodium content because sodium holds on to the water and you basically get a lot of congestion to that. So sometimes I have patients just with sodium restrictions. We do a tremendous job, and they do a tremendous job, and patients don't have to take additional medicines to maintain their congestive symptoms, and they have a good quality of life. So you don't have to use medicines such as diuretics. We'll go on to that into the next slide. Exercise regimen, again, is often put on the back burner, but I encourage my patients to participate in aerobic exercise. Sometimes, depending on what their functional status is, we do refer them for rehabilitation, including for balance or improving their aerobic activity, and then always encourage them because part of the whole heart failure syndrome is that the rest of your organ systems also kind of fall behind, including your musculoskeletal system, and you want to kind of participate in exercise to make you feel better and improve your functional capacity. Weight loss, if you are on the obese side, because as we mentioned, it's a big risk factor for developing congestive heart failure and all of the other risk factors. So we do focus and talk about weight loss. Treatment of medical conditions, especially hypertension. As you go, hypertension is one of the predominant causes of leading to heart failure. So treating hypertension aggressively and with appropriate medications is very, very important. Again, salt restriction will help with management of blood pressure, and that will help with management of congestive heart failure. Ischemia basically means that if you have any ongoing significant blockages in your heart arteries that is contributing to your heart failure syndrome, treating that aggressively also is very, very important, as this will lead to obviously symptom improvement and improvement in your heart function and will help you with management of your congestive heart failure. Sleep apnea is a very often concomitant medical condition that should be aggressively identified and treated because this will lead to improvement in symptoms. I have several patients who have combined multiple medical conditions. All of these are weight-based, weight-related, and you have sleep apnea and you have congestive heart failure. You got to treat their sleep apnea because the treatment will never be complete without addressing that issue. Treating valve disease, so a lot of patients with underlying congestive heart failure develop secondary valve problems or they develop primary valve problems, and treating that also will help with congestive heart failure syndrome. And atrial fibrillation, that's one of my favorites. Again, under-recognized correlationship between atrial fibrillation and heart failure. We do manage atrial fibrillation aggressively, trying to keep the patients in normal heart rhythm as much as possible, and this helps with management of congestive heart failure. In terms of medical treatment, there are, as you can see, the list of medical treatments is huge. There has been several exciting developments in recent times in management of heart failure, which we didn't have in the past. I would say even 25 years ago, treatment included basically diuretics which is still a very important part of treatment, where you basically treat congestion and fluid overload, which will help your heart and help improve your symptoms. So it's definitely a very important part of your therapy, not to be sidelined, but it doesn't improve your survival or prognosis. It obviously will improve your risk of getting hospitalized. So it definitely is a mainstay of treating congestive heart failure, but that's not the only therapy. You have several classes of drugs, and if you do suffer from heart failure, you may have therapies with ACE inhibitors such as lisinopril, or angiotensin receptor blocker therapies such as valsartan, which were the cornerstones of therapy up to about a few years ago, when we have a new drug on the market. And this new therapy are called neprilysin inhibitor therapy, along with angiotensin receptor blockers, something called a sacubitril, valsartan therapy, which is a new therapy. And this is only for patients who have heart failure with reduced ejection fraction. So it's very important to know what kind of heart failure do you have, because most of the therapies, most of the drugs are geared towards patients with heart failure with reduced ejection fraction. There are very limited treatment options with patients with heart failure with preserved ejection fraction, where your pump function is normal. And lot of research and treatment, different treatment options are being considered in those group of patients. But most of these therapies that are being proven therapies to improve survival are patients who have systolic or heart failure with reduced ejection fraction. Beta blockers such as carvedilol, again, you might have heard of that. Again, all these drugs not only improve your symptoms, but are improve your survival. And there's a lot of important scientific data to suggest that. And all of these drugs, heart failure becomes a condition where you are often on many drugs, and that by itself can be challenging for some patients. But it's very, very important to stick with therapies, because you can have improvement in your heart failure. You can have actually improvement in your heart pump function, and once your heart pump function improves, that improves your survival and prognosis significantly. So we want to pay attention to all the medical therapies, and they may be sometimes demanding, but it's important to learn about them and be compliant with them. Mineralocorticoid inhibitors such as aldactone, which is again in patients with advanced heart failure, very significant drug therapy. Most recently, medicines like empagliflozin, which is actually was developed as a diabetic medications, but while doing research, turned out to have a lot of benefit in patients with heart failure, even if they don't have diabetes. So this is really some of the latest treatment guidelines that have been included in treatment for patients with heart failure with reduced ejection fraction. Hydralazine and isordil, these are old medicines, but they have been rebranded in managing heart failure patients, patients who have chronic kidney disease, and more importantly, African American patients, on top of the other therapy, have shown to have improvement in their prognosis with addition of this therapy. Ivabradine, which is again a drug that is used in a very specific patient population. Digoxin, again, in very select population can be used. It's an old drug, 200 or more years old. It still has some role in patients with heart failure with reduced ejection fraction. Select population, if they have atrial fibrillation, can be on anticoagulation. And with very advanced heart failures, you can have home-based infusion therapies, which basically are patients in stage D. Interventional therapies, this includes several therapies, stents and bypass surgery. Again, this is important in patients who have significant reduction to blood flow to the muscle of the heart, and that's causing dysfunction of the heart. Sometimes these therapies can basically reverse heart failure syndrome and are very, very important. Valve replacements, could be surgical valve replacements or could be percutaneous. Most recently, we have catheter-based valve replacements such as transcatheter or aortic valve replacement and correction of mitral regurgitation by MitraClip. There are significant advancement in the recent decade, which has helped several of my patients, and they're a significant part of therapeutic options in some of the patients. Pacemakers, if needed, cardiac resynchronization therapy pacemakers in a certain subgroup of patients, and defibrillators. Defibrillators are basically devices that patients with dysfunction of the heart can have problems because of the pump failure, and most of the medical therapies are designed to help the pump function. but they also had a risk of dying of sudden cardiac death and arrhythmic death, and that's when the defibrillators is very, very important. So a certain select group of patients would benefit with defibrillator therapy. Um, there's also ablations. There are various different types of electrical ablations with catheters, treating atrial fibrillation, treating other ventricular arrhythmias that can be helped and can help patients with congestive heart failure. And in more advanced cases, there's left ventricular assist devices in patients who have very advanced heart failure and basically have stage T heart failure, where you can have assist devices to either as a bridge to take them on to heart transplant, or you can basically have a destination therapy nowadays with left ventricular assist devices. There's been significant improvement in technology, and once considered a very rare therapy is more and more used now in patients with very advanced heart failure. And when all else fails in appropriate patients based on their risk and psychosocial backgrounds, heart transplant is also part of the treatment options for patients with very advanced heart failure. So coming on to, this is the most important part of management of heart failure is monitoring, and this monitoring is important because identifying early increase in fluid base can help us intervene early at home, and patients then can avoid hospitalizations and have continue to have a good quality of life because they're not being hospitalized again and again. And some of the crude methods, although validated methods, are home-based systems. Sometimes we do have visiting nurses go home and help patients with this, but weight monitoring at home and a daily weight monitoring and understanding when you have sudden weight gain that your body is starting to retain salt and water, and intervening early to get diuretics early into your system to improve congestion will often lead to reduction in hospitalization. So although this is crude, but it is available to everybody, and I think it should be used in all patients. Home monitoring of vital signs, including blood pressure, so that we know that blood pressure is well optimized, and the patient is not having side effects to therapy, is again a very important home monitoring tool. Monitoring oxygen saturations is important, but it's not vital to patients to have that. Mostly a good weighing scale that provides you accurate results is very, very important. Very often the doctors will advise repeated blood tests to check your kidneys, and check your heart failure markers, and other blood tests to see how you're improving or are you having any side effects to therapy. So these are very important monitoring tools. Often you'll have very frequent clinic visits, and these are initially more frequent, but as time goes on, you can have less frequent visits once you're on a stable course of treatment. But I think these initial clinic visits and follow-ups are very important because there's reiteration of treatment goals, there's reiteration of education and understanding what's going on. I think, and I do encourage when I have my patients come to clinic to bring their family members so that we can all understand together, sit together, have a discussion. There are lots of remote monitoring options. Some of these advanced pacemakers and defibrillators also have heart failure monitoring algorithms, and very often, your providers are monitoring that on a monthly basis to see if there is early decompensation even before you have weight gain, and we can do an early intervention. And there is a device that has been recently approved called CardioMEMS that is implanted in your pulmonary arteries that also helps you monitor your pressures and help us intervene early to avoid hospitalization. So there's a lot of treatment options out there. There's a lot of monitoring options out there. It is very overwhelming sometimes, but if you have a good provider team taking care of you, I think you can navigate this condition. And it's very important to know about it and treat it and identify it early. Thank you.